Hi, welcome to the Jewish Orthodox Women's Medical Association, JOMA podcast. My name is Elisa Minkin. I am a pediatrician and proud JOMA member, and I'm really excited to be here today with another proud JOMA member, Dr. Sharon Stoll. Hi.
Hi, thanks so much for having me.
My pleasure. Dr. Stoll is a board-certified neurologist and assistant professor in the Department of Neurology at Yale School of Medicine. She completed her neurology residency training at Thomas Jefferson University Hospital in Philadelphia and her neuroimmunology fellowship at Yale New Haven Hospital. She continues to play an active role in academic development and continuing medical education. She is an investigator on several international trials and currently serves on several advisory boards. She has received numerous awards, including Top Neurologist 2019, Rodney Bell Teaching Award, and is a National Multiple Sclerosis Society grant recipient. She also spends time as a medical editor at ABC News, so cool, and is currently a medical commentator for several news outlets and shows, including The Doctors. She has most recently served as the keynote speaker for the annual Women in Science Symposium and is an internationally renowned speaker and patient advocate. So that is incredible. And I saw you on TV. I did watch you. You were amazing. So we just had a town hall just a few days ago, and we had so many questions, and we said we're going to continue to answer the questions because there was no way we were going to answer 200 plus questions in 90 minutes or whatever time we had allotted to it. So this is going to be partially an answer overall the talk, and we're going to get to some at the end maybe, and if not, I believe we're going to be doing an Instagram live together next Thursday. That's going to be confusing for the listeners, the same week you hear this podcast, hopefully. Okay, so let's start by talking about what's now called long COVID or long hauler COVID, because I think that when we talk about what are the risks of the vaccine, a lot of people asked, and this is one of the most common questions is, what are the long-term effects of the vaccine? We have to compare it to the long-term effects of COVID. So I'd like to hear from you what we know about long COVID.
Sure. There's two things to talk about when we talk about long COVID. Long COVID or long hauler syndrome, or whatever anyone wants to call it, postviral encephalitis, all terms to describe the same process or the same phenomenon. And that is months after somebody recovers from COVID, they continue to have muscle aches, malaise, so significant daytime fatigue, brain fog, where they feel like there's a cloud over their head and it's hard to focus, it's hard to concentrate, and headaches, daily headaches or daily migraines. That all falls into the category of long COVID. And then there's this other phenomenon that has been in the news of late, which is a Lancet article that was published a week ago that described new neurologic and psychiatric diseases 6 months after somebody recovers from COVID. And that is separate than this long hauler phenomenon. Those diseases or those symptoms include depression, anxiety, alcohol dependence, mood disorder, and that is separate. That's a separate disease process than this long hauler syndrome.
Does it overlap at all?
I think it does. The article in Lancet didn't discuss long COVID or long hauler COVID. But as a neurologist, there has to be some overlap in terms of depression, anxiety, headache disorder. I know a lot of patients that suffer from headache and migraine do end up having depression and anxiety, insomnia, mood disorder, all of those things that can be associated with it. We also can't ignore what the world has been going through over the past year, which is social isolation, job loss, family loss, and just financial security for a lot of individuals, food security, Zoom school, all of these things definitely play a role. Lack of social interaction with people in a 3D manner.
Mm-hmm.
There's no shortage of Zoom meetings, as we know, but being in close contact with someone, that all definitely plays a part in this.
But I'm confused because are you saying that those are triggers for anxiety and depression outside of disease? They would be, right? Because that's what I was wondering is how do we know this isn't just from the pandemic? And I'm presuming it's because their rate is that much higher.
Right. The Lancet article looked at people that suffer from COVID, and it compared it to people that were diagnosed with influenza, so the flu, and also upper respiratory infection. And because you can also say, well, just suffering from COVID, dealing with COVID, can also set you up for depression and anxiety and alcohol dependence and mood disorder. But what they found was that those syndromes were found to be of statistical significance when compared to other acute respiratory infections.
Right. So people who had them during the COVID pandemic time.
Yes.
Okay. So that
and then to your point, how do you isolate people that recover from COVID versus the general population that have not had COVID? That the article didn't look at.
Mm-hmm.
Other articles, of course, have.
Right. So when we talk about anxiety and depression, we're not really sure how much is from COVID and how much is from all those other factors. But if you go back to long COVID, that really seems to be a specific syndrome.
Yeah. And that's a completely separate syndrome.
Right. And other presentations, like I've heard of it where they have rapid heart rate. They feel like they're going to faint when they stand up, like the posterior orthostatic tachycardia syndrome, the POTS syndrome.
Yeah. So there's other phenomenon. So that autonomic dysfunction hasn't been well described with post-COVID, but we do know, and that might be more with acute COVID. Other things also we know happen with acute disease. So within that 4-week period, or maybe even 8-week period of COVID, in terms of rapid heart rate and heart palpitations, I know a lot of people suffer from new diagnosis of cardiomyopathy, as well as AFib, new diagnosis of AFib after COVID, even if they didn't have significant, whoops, sorry, just trying to shut that off.
A heart rate rhythm abnormality, in case people don't know what AFib is, or
thank you.
Irregular heart rate. Muscle of the heart, right? So
right, and it can give this sense of rapid heart rate or irregular heart rates. And that's been well described with COVID. That goes along with blood clots, DVTs, PEs, and then the cardiomyopathy. So that's all part of the COVID phenomenon. And a lot of that, unfortunately, sometimes doesn't get diagnosed until after somebody recovers from their acute respiratory illness, because they think they're short of breath because they have COVID, rightfully so. They're coughing, they have shortness of breath with exertion, dyspnea with exertion. And then afterwards they find out that no, actually it's from new diagnosis or new onset of AFib. And that's all part of the acute viral illness. But unfortunately, people can still go on to have prolonged AFib, paroxysmal AFib.
So what percentage of people who have COVID go on to have long haul or just chronic symptoms? Do we have any numbers?
Initially with the pandemic, I was seeing reports of 30%, upwards of 30% of people have neurologic psychiatric sequelae after the acute infection. And when I say neurologic and psychiatric, in that matter, I mean headache, chronic fatigue, brain fog, disorders like that persist. And then with the new Lancet article, that was specifically looking at depression, anxiety, alcohol, substance abuse, as well as other neurologic symptoms. So stroke, hemorrhagic stroke, ischemic stroke. And it also looked at other diseases that did not find statistically significant, like Guillain-Barré and Parkinson's disease. I'm not surprised that Guillain-Barré and Parkinson's disease wasn't in a higher rate in COVID patients compared to influenza or other respiratory infection. But it's nice that they looked at it. Why was I not surprised? Because it doesn't, those diseases are not, or I shouldn't say those diseases. Parkinson's disease isn't an autoimmune mediated process. Guillain-Barré is, but we didn't see it with the acute infection. So I'm not surprised that we're not seeing it after the acute infection. It was something that we were considering because it does happen with other illnesses, but it's not seen in higher rates, COVID compared to influenza.
Do we know if these long symptoms are just a prolongation of the same symptoms, or is it a separate syndrome?
Which ones?
I'm talking about the long COVID, the brain fog, for example, one of the most common symptoms. Is that just they're still feeling foggy, or is it a whole new disorder?
We consider it a whole new disorder because, and it's classically called postviral chronic fatigue syndrome in the US. And we see it with other diseases. It's, I don't want to say commonly described in literature, but it's not a surprise when somebody has mono, so Epstein-Barr virus, or Lyme disease, chronic Lyme, that they also have this postviral chronic fatigue syndrome. I also see it just in my subspecialty. I see it with other viral illnesses that we don't have a name for. There's so many viruses that are just not named. Patients recover from the viral illness, but they distinctly remember being sick with some kind of respiratory infectious process. They thought it was the flu or a cold, a really bad cold, maybe with diarrhea, that lasted for a week or two. And then afterwards, they still had body aches, body pains, and even new onset numbness, tingling in different extremities, or full body numbness and tingling, as well as this chronic fatigue with brain fog. And yes, a lot of us experience those symptoms while we're sick, but it's presumed that it's just part of the infection. Your body is fighting an illness. And in addition to feeling run down and being in bed and having muscle aches, you're also coughing and sneezing and have headaches. But for 99% of us, those symptoms do not persist months later.
So for people who get this, how long does it last?
We don't know, because the pandemic, it's been what, 13 months now, 14 months. In my experience, by the time patients like this, the post-viral encephalomyelitis or post-viral chronic fatigue syndrome, by the time they see me, it's usually a year after, or a year to a year and a half after. And I would say for most of my patients, they have complete resolution by the 24-month mark. So by 2 years, the symptoms are gone. And for most, it tends to fade away between 18 months and 24 months.
So you're
But
saying
that's just
right. We don't have the time
experience.
Right. We don't have the time frame for COVID. We don't have that much time.
Right.
So I'm curious because you're saying that these are the same. The long COVID is the same as chronic fatigue and chronic mono and chronic Lyme. And it's just so interesting to me. I have a bunch of things.
I don't know if it's the same.
I've heard it isn't. Yeah.
It seems they suffer from a lot of the same symptoms that I've seen in the other subset of patients that I treat.
Because what I find fascinating about this is up until long COVID, it's been so dismissed by so many in the mainstream community. Oh, the chronic Lyme patient. Oh, the chronic fatigue.
Right.
It doesn't even exist, some people will say.
Right.
It's been dismissed and there's been no markers. And all of a sudden the whole world is getting, long COVID, and it's different.
Now all of a sudden it's a thing.
Yeah,
exactly.
I'm wondering if this is going to help all of those communities of these chronic illnesses.
I think it will.
Yeah.
I really think it will.
So do we have an etiology? Do you know what causes this?
None. No etiology. It's presumed to be a autoimmune process that's going on. A lot of these patients have, and not just for the post-COVID patients, but even for the chronic Lyme or the mono patients, aside from the mono, because now we can see in the cerebral spinal fluid with a spinal tap or a lumbar puncture. With these Lyme patients, they have evidence of Lyme in the past that was adequately treated. CSF is always negative, or at least in my experience, what I see, negative. COVID also, we've done hundreds of spinal taps on these patients, found no evidence of Lyme, COVID in the spinal fluid, and that's even with active COVID infection. And so we think of it as just a COVID virus sets off an autoimmune process that lingers for many months post the infection. And that's kind of why I would separate it from an acute infectious process, because in an acute infection, you have positive serology of the virus, of the bacteria. In this chronic fatigue syndrome or chronic encephalomyelitis phenomenon, we don't have evidence of a lingering infection. So it's not that the immune system is still fighting off an active infection. The active infection is gone, it's cleared the body, but patients still have this disease process lingering. And that's why I believe, or I hypothesize that it's an autoimmune process.
Right. When you say chronic encephalomyelitis, it sounds like there's chronic inflammation. Do we have markers of that? Or are we just calling it that?
We're calling it that. No markers.
Okay,
There's
so
no EEG finding. There's no EMG finding. There's no the CSF. I haven't tapped any of these patients, so I don't know. I can't say. But for a lot of other patients, they might have an elevated protein in the spinal fluid, which does indicate some lingering autoimmune process, possibly, but the white count is generally normal.
Mm-hmm.
So no active CNS inflammatory process. So that's one of the reasons that chronic fatigue syndrome was always dismissed as you're crazy,
right?
It's all in your head. It doesn't make any sense because there are no markers.
Are we seeing a difference with men versus women for this?
In literature,
right into that, not people not believing us and gaslighting us.
Yeah. No, so I smile because in literature for post-COVID, there have been reports that it's more common in women.
Mm-hmm.
In my own clinical experience with the chronic fatigue syndrome, I think almost every single one of the patients that I've seen and treated have been men in their 30s,
really,
otherwise healthy, no comorbidity, no obesity, diabetes, hypertension, hyperlipidemia, all extremely active, healthy, otherwise Caucasian, generally men in their 30s that come in with this.
And this is after COVID?
No, with my patient subset, the chronic fatigue patient subset, they've been men.
Mm-hmm.
And again, I have not treated, full disclaimer, I shouldn't say I haven't treated. I have treated, or I have patients that suffer from post-COVID syndrome, but they have been established patients of mine in my practice. Mm-hmm. I have not opened my clinic up to treating post-COVID long haulers.
Now there's a clinic, right? I think it's at Mount Sinai that does this.
Yes, there are clinics. There's a few. I think there's one in Cleveland Clinic as well. I think Cleveland Clinic has a specific neuro clinic for post-COVID.
Right. For people listening to this, many are from the New York area or New Jersey.
Yeah.
Area. I would think that the closest one would be I think it's Mount Sinai.
Yeah. Yeah.
So what do they do to treat this?
That I'm not sure, but actually, I was just reading an article that, and we're doing a lot of research at Yale. There's the PI for a large clinical trial is happening at Yale for post-COVID long hauler syndrome, whatever you want to call it, getting vaccinated and looking at recovery of the symptoms post-vaccine. And there was some preliminary data that was published that 30 to 40% of patients that do have this phenomenon or this condition have improvement after the vaccine. I think it's about 2 weeks after the vaccine. And about 10 to 15% of those patients reported slight worsening of those symptoms. And the other patients reported no change, but 30 to 40%, that's pretty significant improvement with the vaccine.
Right. So to summarize, almost half of people who have long COVID will get better when they get the COVID vaccine, which a lot of people who've had COVID think they shouldn't get or don't need to get the COVID vaccine, especially if they are chronically ill. They may feel like they're somehow immune compromised and therefore somehow more at risk. So it's a really important point that you have a good chance of feeling better after the vaccine and a smaller chance of feeling worse.
Right.
So
I
just
kind of think
update
of
that.
it as similar to the, so I'm a neuroimmunologist. I treat autoimmune conditions of the brain and the spinal cord. And so this is kind of right up my alley when I try and explain to somebody, and this is common knowledge with rheumatologists and rheumatologic conditions similar to multiple sclerosis, which is basically a rheumatologic condition of the brain. People with autoimmune diseases often feel better when they're pregnant. And a lot of people wonder, well, why? This doesn't make any sense. You should feel worse. Everyone feels worse when they're pregnant. And the way I explain it is it's kind of like your immune system is going haywire. It thinks that your brain and your spinal cord are an infection, a virus, and it attacks it. When you're pregnant, you have this foreign substance or foreign, let's say, bacteria in your body, and your immune system is kind of quieted down because it's looking at this baby or this embryo and just trying to figure out what to do with it. And it does everything it can to not attack it because it is foreign to the mother. And that kind of quiescence all of the autoimmune diseases that someone has when they're pregnant, which is why a lot of women feel better when they're pregnant if they have an autoimmune disease. And the way I look at the vaccine, and I could be completely wrong, this is just a theory I have, but when somebody gets the vaccine for COVID, your immune process, if your immune system is what is attacking or flaring up, it's kind of hyper aware of what's going on, and it's trying to figure out what to do. It recognizes the vaccine as, okay, now here's this foreign thing in the body. I'm going to try and figure out what to do. And it auto-regulates itself and kind of quiets down this hyperactive immune process that's going on. And I mean, again, all theory, but
right, we don't know. But people are asking, I'm glad you're saying this, because people are asking specifically for people with autoimmune conditions. There's two questions. I'll ask them both. Yeah. Question number one is for people with autoimmune conditions, are they contraindicated to get the vaccine? And the flip side, is there a risk of getting an autoimmune condition with the vaccine?
Right. Great question. Two things. There's the mRNA vaccine and the adenovirus vector vaccine. So I'm going to answer the mRNA vaccine because it's a new vaccine. It's a new mechanism. We don't have a lot of data. We don't have long-term studies. So we don't know down the line, long-term, if people with autoimmune diseases they'll have. So I can answer if people will have acute worsening of their autoimmune disease post-vaccine, because now millions of people have gotten the vaccine, and a number of those have had autoimmune diseases. I'm updated with the MS population. And just looking at raw numbers, it does not, number one, we are recommending it for MS and other neuroautoimmune diseases. We are recommending getting vaccinated. And that's the same thing for people with neurologic conditions that are on immunomodulating medication. So medications that weaken the immune system, again, we are recommending getting vaccinated. People with central nervous system antibodies, so paraneoplastic diseases, again, we are recommending getting vaccinated. So I can say that. In terms of rheumatology, I believe that they are also recommending vaccination, but similar to my specialty, depending on which medication or which immunomodulatory or immunosuppressant medication somebody is on, they should talk to their physician about a timeline, because a lot of these medications are not daily. They're once a week or once a month or once every 6 months. So there is a preferable time course for when to get vaccinated, and the timeline of the immunomodulatory or immunosuppressant medication that you're on. So before scheduling that vaccine, you want to check with your doctor to make sure that it's spaced out appropriately with your medication. So that's number one. Number two, in terms of the adenovirus vector vaccine, getting the vaccine is always better. Getting a vaccine for COVID is always better than not getting a vaccine for COVID. Having said that, now J&J took their the vaccine off the market, but I'm sure that it'll be back on the market in a matter of days. When that comes back out, the one thing that I am somewhat weary of with the adenovirus vector vaccine, especially J&J, because it's a one dose, is just the antibody level production with the vaccine. So the data that come out that said that it's fantastic in terms of suppressing hospitalization and suppressing chronic severe outcome from the virus itself is fantastic. And that's what we want. But in terms of not getting COVID, I think the rate was 55%. If somebody is on an immunosuppressant, then their ability to mount antibodies is going to be lower to start with. So that's the one thing that I always caution about for those that are on an immunosuppressant. It's not that the immunosuppressant makes the vaccine dangerous. That's a common misconception. It's that it would make it ineffective or less effective, not that it would make it dangerous. So just want to clear up that myth.
Right. And I think the take home is that if you have some kind of condition where your immune system may be, not up to par, you should, of course, talk to your doctor first, have that conversation, make the decision with them. You should get it, how much more so, but you may need to take extra precautions because you may not mount as good a response. You may remain more vulnerable.
Exactly. And somebody that would get a vaccine, they may have a false sense of security that now I can go out and do everything that I did pre-COVID because I'm fully protected. And depending on your antibody response, you may be not fully protected, but it doesn't mean the vaccine will be dangerous. So I think that answers hopefully question number one. And then question number two, I forgot about already. So
before we get there, I just want to say, because I was thinking of something I wanted to say, which is that it's very hard to tell people you have your vaccine and you still have to be so cautious. And I think that different people are going to have different risk benefit equations. Mm-hmm. But for someone who already has a medical condition, they should really be careful. Or if they're older.
Yeah, absolutely.
Right? People who are elderly historically don't mount as good an immune response, though the vaccine seemed to be better than expected. I'm very excited about that. Yeah. But one of the questions we got was somebody in her 70s who said, I want to go to a wedding and I want to dance and can I do all these things? And my answer was, especially now, right, where we don't have herd immunity, where we only have a relatively small percentage of people vaccinated, and you're more at risk because you're older. We don't know your response is as good. And that's the same thing for people who are immune compromised. You should be more careful.
Right.
I think that's a really important message, even though it can be hard to take, because then why did I get the vaccine? Right. And I think about it like you got a nice coat to go out in the cold weather, but if the weather's colder, you add another layer.
Yeah.
Right.
That's a great analogy.
Very simple analogy to get to that. Okay. So the other question was, the first question was about, oh my gosh, I forgot to. I'm gonna have to come back.
I remember now. It was, does it cause autoimmune diseases?
Yes, thank you.
Yeah.
People asked so much about long-term effects. And I mean, honestly, of course, we don't know long-term effects. We haven't had the vaccine out for a long term.
Yeah.
So does it cause long-term or autoimmune effects, the vaccine?
Sure. So what we see in short term, at least what I've seen and what I've read about for my specialty, which is multiple sclerosis, is that we do not see worsening of somebody's MS, new lesions, new relapses, post-COVID vaccine. It's not something that has been reported, and it's not something that that we've been noticing. In terms of other autoimmune conditions that I'm not as well versed in, so I'm gonna stay in my lane, as they say. And in terms of someone being newly diagnosed, having a new autoimmune condition that they've never had before, that also is not being reported, which is fantastic. Fantastic news.
Right, but when someone says long-term, we don't have long-term data.
Right, there's no long-term data.
I think it goes back to, what did we just say about COVID long-term? We said the risk of long-term problems with COVID is very high.
Right.
And so I think that
Sure.
to remember is you're not making a
The
decision.
risk of short-term COVID is very high.
Right, right. But once
That's also
you get
something
it,
that we have
right.
to keep in mind because, you know, a year ago, the New York area was completely devastated by this disease. People were dying literally left and right because of COVID. And that's something that we shouldn't be quick to forget where we were a year ago.
Right, it's so true. You know, a lot of communities have had so much COVID then that they feel that they have herd immunity now.
Right.
Now, I don't know, I would love to hear your opinion on that. I have my opinion.
I want to hear your opinion, and then I want to share.
So my opinion is that they don't have herd immunity, but they have less spread because they've had more disease. So it's not spreading, you know, as widely there. And I think that people who are highest risk may have, you know, be taking more precautions, and people who are having lower risk may not know they're getting it asymptomatically or mildly not testing. I still think it's circulating in the community, but milder and at a lower rate.
Yeah. I think one of the reasons in terms of herd immunity, I think it's a little different with COVID. At least we're seeing that now a year later, especially looking at other countries that have always been more open than certain states in the US. People are starting to get reinfected. And that was one of the initial questions that we had. Well, I have COVID, now I'm protected. I don't know how long. Everyone was saying, okay, you're good for 90 days. So that was kind of like the cutoff for 3 months. Great, I'm protected. But, you know, we all kind of speculated that we're probably still protected longer than that 90-day period. But saying 90 days is really the, let's say the 90% mark. You know, 90% of people are protected for that 90-day period. Whether or not some people can be protected or have antibodies for 12 months, time will tell, or what percentage of people will have antibodies, you know, into the following year. And it's something that we have to keep in mind, that COVID is a SARS-2 virus. It is not like it's not like chickenpox. It's not you get it once and you never get it again. And we need herd immunity to we have to reach that 70% mark, and then we'll all be protected for the rest of our lives. And it's something that we don't have to worry about now. It's not like the flu you get, or it's more like the flu, where you get sick 1 year and a year later you can get the flu again. It doesn't mean you have herd immunity lifelong. And now coming into, or well into, the second year of COVID, we're starting to see reinfection rates. So it's this rolling effect that one of the reasons we were so devastated early on was because it was a novel virus and no one had any exposure to it. We're waiting to reach a 70% mark, where 70% of people have had some exposure to COVID. And it doesn't mean you won't get it again, but the next time you get it, you won't have as severe of a course. And that's something, one question that we have for the vaccine is, how long will you be protected from the vaccine? Does the vaccine provide 1 year protection, 5 years protection? When do we need boosters? When do we need, at what point should you check serology to see, you know, your immune response if you still have antibodies? So that's another question. One thing that I've been following from the beginning, because again, it's just a question that I always had for my patients. And I didn't want to wait for the published data to come out. I wanted to see what was going on in real time, was I was checking antibodies for my patients before and after immunomodulatory medication, especially somebody that told me that they had COVID. I wanted to see, were these patients able to mount an immune response, a proper immune response? And then if I hit them with an immunosuppressant, 2 months later, did they still have those antibodies? And what I saw was they did, but it was reduced in a good number of patients. However, I don't know if one of the other questions that you had was, is it B cell mediated, T cell mediated? What do the antibodies even mean? If you don't have antibodies, well, you can still have protection.
Yes, people they did. Good call there.
An educated group.
Yes.
As we
Oh,
know.
yes. Great question.
So to answer some of that, I can tell you with B cell suppression, patients can still mount an immune response and have antibodies. And even if the antibodies are zero, I have had patients that have been in close contact with COVID positive individuals for longer than 15 minutes and have not had a reinfection. But again, that's more, that's not a study, that's just a one-off or a simple event of one.
And you don't know, and actually it's a personal pet peeve of mine for people to say, well, I have antibodies, so I'm good, because it goes both ways. You could have no antibodies and still have the ability to mount an immune response, right? Either through memory B cells or your T cell, which is a different arm of the immune system. Or you could have them and they could not be effective because we haven't even mentioned the variant strains. Or the variants, not separate strains, they're variation, the variants. And that is really a problem, especially in terms of reinfection, because it is so much more infectious, and the antibodies you have may not be what are so-called neutralizing antibodies for the newer strain.
They could be dysfunctional antibodies also.
Right.
It can come up in your bloodstream, but they can be completely dysfunctional and not work properly.
Right. Or just not have enough. My understanding is you need 17 times the number of antibodies to neutralize the UK strain, or I think it's the UK strain, or whatever one of the variants are that is circulating very widely. And another thing also is for someone who had COVID, but doesn't have a strong immune system, and you don't necessarily know who you are, you may no longer be immune and be, just as susceptible to reinfection as someone who never had it. And I think it's something like 50% of older people above the age of 60 something lose their ability, lose their immunity after a certain period of time.
Yeah.
So those are all things to keep in mind. Another person asked us, several people asked us, so what if I'm low risk? Do I really need the vaccine? Shouldn't the vaccine be saved for those who are high risk?
No, because somebody at low risk is the one that's going to be going out and spreading the virus to those that are high risk. So no, everyone should be vaccinated, especially those that are at low risk, because it's one thing to protect yourself, but it's another thing to protect the community.
Right, but a lot of people will say, I care about me. I want to know, I don't want to take a risk for me, for someone else. Don't throw me under the bus. And I think the correct answer, in addition to what you said, which is of course correct, which is you have to protect others, even people who may not be as severely ill. If you're young and healthy, you're likely to do fine, is first of all what we just said about long COVID. Long COVID affects young people too.
Yep, absolutely. And people
children, which terrifies me as a pediatrician.
That what terrifies you?
To see it in children.
Oh, yeah.
I don't think it's well studied, but I'm hearing 15% or something from the little studies they have long-term effects. And by the way, we have to, as pediatricians, we now have to check children 5 and up 2 weeks after COVID to see if they can go back to, their physical education, that they don't have any long-term cardiac or pulmonary sequelae of this. 5.
Yeah.
And I've had to refer some children to specialists because they're still out of breath easily. They feel their heart is racing, and these are children.
Yeah.
So the idea that we have a low risk population for a disease like this, I think, is just wrong.
Yeah. And, it's not just the, so again, the long COVID, but the, trust me, no one wants to deal with persistent brain fog and chronic fatigue and chronic headache months after. So something that I didn't talk about was I actually got COVID and my whole family got COVID May of last year. And I think I was in bed for a week straight with horrible migraines. And even after I wasn't short of breath with just lying in bed, walking to the mailbox 3 weeks after I got sick, I had to take a break before walking back into the house. And so I didn't go to the hospital. I wasn't considered to be in that hospitalized or severe COVID. And I'm otherwise young and healthy, if I can say that.
Yes.
And then post-COVID, so not only did I lose my sense of smell, which was fine, not the end of the world. And it took months to come back. But I developed new onset daily persistent headache. And I didn't realize that I was popping Advil every day, multiple times a day, just to get through the day. And then I started going on a preventative headache medication months after I had COVID. So that's not something that you want to deal with, because number one, you might think, sure, okay, headache, no big deal. I could just pop some Advil and it goes away. Yes, I've done that. But you don't want to have to look for a neurologist in these days, because unfortunately, it's hard to get an appointment, especially with a headache specialist. I'm lucky because I know one. But, you know, so it was easy for me to, you know, to have access to the right medication, but you don't want to deal with new daily persistent headache. That in itself can be debilitating for somebody that works a number of hours a day and watches children.
Right. And I think that that's a take-home message,
Yeah.
that it's not just, you know, whether you, God forbid, die of COVID, you know, or even have to go to the hospital. It's what we, you know, call the morbidity, the disease, all the problems that happen after, and that you
Yep.
have to weigh the theoretical risks of the vaccine with the actual known risks of the disease and its after effects.
Right. Right. And post-vaccine, my husband and I both, you know, we had the really sore arm. That happens. And we had full body aches, chills, shortness of breath in bed for, you know, a good 12 hours after. And what I tell everybody when they ask, you know, how did you do? How, you know, and I don't lie. I don't undermine or diminish what the vaccine can do a day later or 2 days later. But I always say 12 hours of these symptoms is much better than 4 weeks of these symptoms. And if you think that, oh, you're young and healthy and you have no issues, you're going to be just fine, just think of 4 weeks of this. Or after you get the vaccine, if you think those symptoms are bad, again, think of those symptoms for 4 weeks, because it's a lot worse.
Right. And then for months afterwards.
And for months
years
after.
afterwards.
Exactly.
So I want to
There's
thank you.
no question
Right.
about pros versus cons. You know, as physicians, we always, it's a occupational hazard that we're always weighing risk versus benefit. This is not even a question in our mind in terms of risk versus benefit of vaccine. It's the benefit of vaccine is here and the risk of the vaccine is on the ground.
Right. You and many other doctors who had COVID ran to get the vaccine.
Yep.
No question in your minds. I think a lot of
Ran.
people are scared that if they get the vaccine after COVID, it's going to somehow give them a cytokine storm or some kind of, you know, autoimmune something or other. And that is not true.
No, the only difference is that a lot of people with the Moderna and the Pfizer, if you don't have COVID, you might get those reactions, what I discussed after the second vaccine. If you do have COVID, then your body is already mounting this immune response with the first vaccine instead of the second vaccine. That's the only difference.
Right. And that's not even 100% across the board.
Nope, not 100%. It's
right. Thank you so much for doing this with me. And we're going to have to continue with the questions because I left some over for our Instagram on Thursday, April 22nd. Right? Is that next Thursday?
Yes.
I'll see you then. Thank you so much.
All right, great. Take care. Thank you for having me.
Thank you.